Hello, this is Anthony Effinger. I'm your host at the Think Neuro podcast from Pacific Neuroscience Institute. And today we are talking with Dr. Neil Martin. He is a neurosurgeon and he's the Director of Innovation and Quality at PNI. Dr. Martin, thanks for joining us.
Hi, Anthony. Great to be here with you.
When did you know you were going to be a neurosurgeon in your life?
It was in my third year of medical school, frankly. I did a rotation on neurosurgery and just was completely enamored of the complexity of the field and the opportunity to personally do complex operations and result in, tremendous recovery for patients from devastating diseases. So I was hooked as soon as I got a real exposure to it.
And where was that?
I was a medical student at the Medical College of Virginia in Richmond. And after that, I went on to neurosurgical residency at the University of California in San Francisco with a famous neurosurgeon, Charlie Wilson. And then after that, spent a year in Phoenix at the Barrow Neurological Institute and then worked at UCLA for over 3 decades.
What was Dr. Wilson, what was his claim to fame?
Dr. Wilson was one of the hardest working people you would ever come to meet. He could be both charming and frightening. He was only about 5'8" feet tall, weighed about 120 pounds, but he was a tiger and amazing neurosurgeon, one of the leading neurosurgeons in the world, and also a marathon runner. And so I had the privilege of training for marathons and ultra marathons with him in the later years of my residency, a unique experience.
How long did you work with him?
6 years. I was in San Francisco for 6 years.
Okay. And when did you do your first procedure?
Well, as a resident, when I was at the San Francisco General Hospital, I actually did procedures along with one of the faculty members. And later in my residency as well with Dr. Wilson. But solo, my first procedure was in October of 1985.
It sounds like you remember it well.
I remember it very well. It was a ruptured aneurysm in a gentleman who'd had a serious hemorrhage from the aneurysm. Relatively high-risk case, not the easiest first case ever, but fortunately everything went well. He made it through and returned home doing quite well afterwards.
Now tell us, an aneurysm, remind us again what happens there.
Yeah, an aneurysm is a weakened spot in a brain artery. Of course, the arteries are the high-pressure blood vessels that take blood from the heart to the brain. And the brain arteries are unique in that they have an unusually thin wall. They're not reinforced by multiple layers of tissue like they are in the rest of the body. So if you develop a weakened spot, it can rupture and cause bleeding over the surface of the brain, a subarachnoid hemorrhage that's called. And that's one of the specialties that I had in neurosurgery was treating blood vessel abnormalities. So that case was the first of over 1,000 craniotomies, brain surgeries for aneurysms. It's a field that's evolved dramatically. Many of those aneurysms are treated now with endovascular techniques, catheter techniques like a heart angioplasty, where the catheter goes right up inside the brain artery, inside the head, and deposits material, usually a platinum coil inside the aneurysm, and blocks it off from the inside. So open surgery is only required for the most complicated aneurysms today.
Why platinum?
Well, platinum is a relatively non-reactive metal, so it doesn't rust or degrade over time. Its durability is tremendous, and it can be woven into a very soft, floppy, coil-like material that assumes the shape of an aneurysm and allows you to pack it off from the inside without putting too much pressure on the aneurysm.
Oh, that's fascinating. So tell us about your practice now at PNI. What do you see every week?
So at PNI, I'm still seeing patients with blood vessel abnormalities, brain aneurysms, arteriovenous malformations, which is a cluster of abnormal blood vessels in the brain that can cause bleeding or seizures. And I'm also seeing patients with cranial nerve disorders, particularly the ones that are related to compression, micro compression of the cranial nerve inside the head. This is a phenomenon that can cause a variety of clinical problems. So if the nerve that provides sensation to the face is compressed, then this can cause trigeminal neuralgia, which is an episodic, sharp, knife-like pain to one side of the face. It's been called the suicide disease because in days before we had good treatments for it, it was so severe that patients would try anything to escape the pain. So trigeminal neuralgia is one form. Hemifacial spasm, we'll talk about that a little bit today. Hemifacial spasm is another. If the nerve involved is the facial nerve, which is the nerve that provides movement to the face, not sensation, like the trigeminal nerve, then if that becomes involved, you also have episodes of hyperactivity of the nerve, but in this case, it's movement, it's twitching, it's spasming of the facial muscles, quite disfiguring. It's not really painful, but it is socially handicapping, and it's a huge cosmetic problem for people. And because it can often cause spasming and tonic closure of the eye, it really can impair somebody's functioning to a certain degree.
Tonic closing of the eye?
So ordinarily this causes episodes of spasm, twitching of the face and the eyelid. If it becomes extremely severe, then it can cause the equivalent of a cramp, tightening of the muscles that doesn't relent for minutes or longer. And if your eye gets squeezed shut and you're driving, that can be a distraction and a hazard. If you do a dangerous job, it's really a major impediment. But for most people, interacting socially is so critically important, and this is hugely distracting. It looks very abnormal, and it really impairs a person's social life, their business interactions, and it's tremendously bothersome.
So what does one side of the face look sort of contorted and cramped?
So part of the time a person can look entirely normal, but when the spasming occurs, and it's a little bit unpredictable, it often comes on when a person's fatigued or stressed, then this occurs. And it's very disfiguring contraction of one side of the face with vigorous closure of the eye and wrinkling of the nose and contraction of the cheek and the mouth area. It looks like someone is making faces at you with one side of their face. And most people don't have any understanding of this syndrome. And when they see it, it's disturbing. It's off-putting because they don't understand. There's a real biological disorder that's causing this. The person isn't acting in a bizarre way for any non-biological reason, for some psychological disturbance. It's a biological phenomenon that they have no control over.
So what's the cause here? Where does this nerve run?
Well, the nerve runs.
Yeah.
It originates in the brainstem. Now, the brainstem is an extension of the spinal cord as it enters the brain, down at the base of your skull, and from the side of the brainstem, numerous nerves arise, like the trigeminal nerve for facial sensation, like the vestibulocochlear nerve, which provides hearing and balance, like the facial nerve, which provides movement of the face, and nerves that go towards the throat and the swallowing mechanisms. So these nerves are traveling through the fluid space before they exit specific openings in the skull to go on to their destination in the face or the throat. If there's a very vulnerable area, a few millimeters, less than a quarter of an inch beyond where they come out of the brain, where the components of the nerve change. A nerve is a bundle of biological wires that provide control to the body or provide perception and sensation. And each one of those wires, the nerve filaments from neurons, is insulated from its nearby neighbors by a cellular layer that's called the Schwann cells. And these cells allow for very organized nerve impulse conduction through the nerve, just like electric current, if you will. That is the mechanism for nerve action and nerve communication. So in the case of hemifacial spasm and trigeminal neuralgia, the nerve loses its insulation. And in these cases, we found that it's usually caused by chronic compression from a blood vessel that just happens to be too close to the nerve. So with every heartbeat, the blood vessel is compressing the nerve over and over again, 70 times a minute, 24 hours a day. And over time, that can wear away the insulation in the nerve, cause short circuiting. And so one gets, instead of the smooth action of the nerve to provide normal synchronous contraction of the muscles in the face, for instance, when you smile or when you're talking or frowning, you get flashes of nerve activity that result in this kind of spasming of the muscles in the face. Hemifacial spasm, hemi for one side of the face.
So where is this critical spot on the nerve? In the back of your, where, if you had to point to it, where would you point?
It's straight in from right here. It's
from
halfway between my fingers, right at the base of the skull, right in the middle.
You've got your fingers up kind of behind your ears.
Yeah, it's lower down. It's not up in the cerebrum, the main cognitive and memory center for the brain. It's down at the brainstem where the brain connects to the spinal cord lower at the base of your neck.
Okay.
And so the spot that's vulnerable, you can recognize it with experience. It's a couple of millimeters distant from the area where the nerve comes out of the brain tissue. And there can be two or three different nerves two or three different arteries that cause this kind of compression. In some cases, you can actually see the area of compression in the abnormal blood vessel on a high resolution brain MRI scan. But in other cases, it's so subtle and the artery is so small you can't see it. But this syndrome is so characteristic that the symptoms alone give you about a 98% assurance that this is a problem. It starts with twitching right around the eye, which everybody, you and I, have had from time to time when we have too much caffeine, when we get too tired. That little twitching around your eyelid is a normal muscle fasciculation. That's not hemifacial spasm, but hemifacial spasm begins in a very similar way. But rapidly, it extends to involve not only the lower eyelid, but the upper eyelid, then the muscles around the eye, then the cheek, the jaw, even the muscles of the neck can be involved over time. So, everybody out there who occasionally has a little twitching around your eye, you don't need to panic. 1 in 1,000 times that evolves into hemifacial spasm. So it's a normal muscle irritation.
Is this just a bad luck of anatomy that some people are afflicted with this?
It's an accident of nature, Anthony. All of these nerves are surrounded by a network of blood vessels that supply the critical nutrition, oxygen and glucose, sugar to the brain to keep it running. And the brain requires a tremendous amount of energy to function. 20% of the flow from your heart goes to your brain. And so the blood vessels form a rich network on the surface of the brain. And in the vast majority of people, they don't hit that one little vulnerable area of the trigeminal or the facial nerve. But when they do, they can cause this kind of a syndrome. Over time, blood vessels have a tendency to elongate a bit with age. And if they elongate, they start to develop a kink or a curvature. And that curvature then can impact the nerve. And gradually over time, damage the nerve and cause this kind of dysfunction.
And now a message from our sponsor. The Think Neuro podcast is brought to you by Pacific Neuroscience Institute Foundation, a nonprofit 501c3 organization. If you're inspired by what you hear and wish to support our mission of education through innovation, please visit pacificneuro.org/foundation. So tell us what you do in your procedure.
Well, it's not necessary to do brain surgery for everybody who has hemifacial spasm. And mild cases often can be controlled quite well with temporary paralysis of the facial muscles, as can be done with Botox injections. So just like Botox will erase the wrinkles in your forehead, Botox can cause enough weakness in the muscles of your face that this kind of spasming will stop. Sometimes there's a bit of an overshoot, and so you get facial weakness. That side of the face will actually droop for a while until the Botox starts to wear off in a month or so. And then over the course of 2 or 3 or 4 months, generally the effect wears off and the spasm comes back. So for some people with mild spasm, that's a very reasonable symptomatic treatment. It doesn't get to the heart of the matter. It doesn't get to the underlying cause. It doesn't cure the problem. It's a Band-Aid. Unfortunately, there's no oral medication you can take that really is very effective for hemifacial spasm. Many have been tried. Almost nothing really works, and patients are generally more dissatisfied with the side effects of the medication and unimpressed with the improvement they get. But Botox is a reasonable alternative. However, in some people, the effect starts wearing off over years, and for control, you have to have this injection every 3 or 4 months indefinitely. So it's not a trivial commitment.
Okay, so then
the surgery you asked about.
Yeah.
The surgery involves making a small opening just behind the ear. It's usually the size of a nickel, and the incision is just over an inch. And through that opening, if you make it in precisely the right spot over the area of the facial nerve, then using a surgical microscope and the endoscope, you can see the facial nerve clearly. And it's possible to identify the blood vessel causing the compression. With experience, it's quite obvious. And then the blood vessel is bonded to the surface of the brain with small spider web-like fibrils, the arachnoid. And those have to be cut. They don't have a function beyond structural. And if those are cut, then you can displace the artery away from the nerve, take the pressure off. And in order to maintain that decompression, we generally put a small Teflon felt pad in there. We're talking about something that, is very small, the size of an orange seed, perhaps.
Yeah, I was going to ask, the geometries here that's what we're talking about. Is that sort of sizes?
That's right. It's quite small. And so we carefully, with an instrument in one hand, elevate the blood vessel away from the nerve and interpose a cushioning Teflon felt pad. And then often with a little bit of biological glue, we fix it in place. And that solves the problem.
Biological glue?
It's glue that's made from the same proteins that form a blood clot.
Interesting.
And it's commercially available. It's prepared, and it can be used to adhere the felt pad in place until a tiny amount of fibrous tissue will fix it permanently in place.
So what's in your hands when you're doing this procedure? What are the instruments?
So in order to make in the opening, we use a micro drill and drill away a little bit of bone, as I say, an opening the size of a nickel. And once we open the leathery covering of the brain, the dura, then we see the posterior part of the brain, the cerebellum. And with a little gentle retraction and draining of the cerebrospinal fluid, then we can see the nerve. The entire operation requires the use of a surgical microscope that's magnifying things 10 times, 20 times, so that we can see every tiny detail. And then in one hand, one uses a probe or a small thin suction catheter made of metal to elevate the blood vessel. The little arachnoid adhesions that hold blood vessels in place are cut with micro scissors, and then using a micro forceps, we put the Teflon felt pad in place. Now, Anthony, in some cases, the nerve is almost around the corner of the brainstem and can be a little hard to identify without making a very large opening. And in those cases, we often use the endoscope, just as used to scope your knee. And the endoscope, which is about anywhere from 2 to 4 millimeters in diameter, can be introduced right next to the nerve. We can see around corners, and we can make sure that we've identified all the areas of compression.
Fascinating. How long is this procedure take usually?
Usually takes an hour and a half.
That's it?
Yeah.
In and out.
In and out. The anatomy, if you're a fan of neuroanatomy, the anatomy is beautiful. You can actually see every cranial nerve very clearly. You can see the blood vessels well. So it's that perfect surgical circumstance where there's a visible structural abnormality that you can correct and reverse the whole clinical syndrome. In other words, eliminate all the symptoms.
And that must be gratifying.
It's extremely gratifying during surgery. You can almost hear the nerve breathe a sigh of relief as you decompress it. And the real reward comes when you talk to the patients afterwards and their face is no longer twitching.
Is it immediate?
Well, that's a good question. For some, there's several patterns that occur. In some patients, they wake up after surgery and there's never another twitching again. Some people will wake up and the twitching is unchanged, but the nerve is now in the healing phase. And in weeks or months, sometimes the twitching fades away. Sometimes it's gone immediately from the immediate effect of the surgery. Then the twitching comes back for a little bit. That's frightening for a patient. They think it didn't work, but with a little reassurance, they get rid of it. And more than 95% in my experience, more than 95% of patients are completely relieved of the twitching after this kind of surgery. So it's life-changing for people like this. And these are the happiest, most grateful patients you can imagine.
Yeah, I mean, is there anything else in your area of work that has this sort of success and immediate, and obvious, improvements?
Well, frankly, it's the other microvascular compression syndrome, trigeminal neuralgia, which also has the same kind of tremendous outcome for patients. In this case, this excruciating knife-like, electric shock-like pain is gone. And, they live their lives sort of tensed up, waiting for the pain to come at any unexpected moment. And when that's gone, they don't even believe it until days or weeks go by and they have no more episodes of pain. And so that, those patients are equal or even more grateful than the hemifacial spasm patients. But
is that the same idea here, that you're going in and getting an artery off of the trigeminal nerve?
Right.
But in this case, it's a sensory nerve, not a motor nerve.
It's about 3/4 of an inch away.
So it's the same neighborhood.
Same neighborhood, same phenomenon. The trigeminal nerve, relatively speaking, is a pretty substantial, hefty nerve, probably 5 times the diameter of the facial nerve.
Which is how big then? So how big does that make it?
About 1 millimeter in diameter.
So that's a big nerve.
Relatively speaking, that's a big nerve. Many of them are smaller than that.
1 millimeter.
Yeah.
And these things when you see them, obviously.
Yeah, with some experience. It's a bit of a thicket of critical structures when you first go in there, but they all have well-established positions and relationships one to another, and so you can work it out as you do it the first few times if you've studied the anatomy, and after you've done it several hundred times like I have, you recognize the problem immediately.
What color is the trigeminal nerve?
It's an ivory color.
Interesting. Okay, so it's ivory on a background of what? Like what else is around it?
The sort of tan or yellowish surface of the brainstem.
Is that also include? Is that what color the cerebellum is too?
Yeah, the cerebellum has a different structure, but more or less the same color of all of the brain tissue. The brain is encompassed by what's called the pia. Well, the pia is the skin of the brain, and so it has this color.
Is the pia different from the dura?
Yeah, there are several layers between the brain tissue itself and the inner surface of the skull. The pia is the skin of the brain. Then there is a fluid-filled space filled with cerebrospinal fluid. That's where we're working for these nerves. They go through this fluid-filled space called the subarachnoid space. Now, it's not much space. It's only a couple millimeters wide. And then there's the arachnoid. The arachnoid is the saran wrap-like layer that encloses the cerebrospinal fluid and keeps it over the surface of the brain. In fact, the brain is floating essentially in the cerebrospinal fluid. And then outside of that is the dura, which is like leather. It's like a thin layer of leathery, strong tissue that protects the brain.
Is it a big deal to breach that?
Patients take a few days to recover after you've gone in and done this sort of operation. On the way out, we repair each layer as much as possible. And the healing process will seal things up once we've finished. The dura gets sutured together just like a leather garment. And so it's closed up and restored in its normal location. And then the opening in the bone can be repaired with biological bone cement, or it can be filled with a tiny bit of fat taken from the lower part of the abdomen in some people. And then we often cover the hole up with a very thin titanium, star-shaped titanium plate that seals it. The opening is small enough, one's not left vulnerable. It's not a weak spot in the skull that exposes you to trauma. And as I said, it's the size of a nickel, maybe a hair bigger than that.
So you're not putting back the piece, you're putting back other material that's going to seal that.
It's such a small opening. It's hard to cut out a piece of that size. And the opening has to be quite close to some of the large venous structures that travel through the dura. So you want to be very careful with microsurgical drilling that you don't get any tears in that, which can cause some bleeding. So very often it's difficult to cut out a plug of tissue and then replace it. Not impossible, and it can be done in some cases, but most of the time we drill it away very carefully and then replace it either with a biological bone cement that's made out of the same kind of constituents that your natural bone is. It goes in like putty and then hardens very quickly. Or a little bit of fatty tissue is plenty to seal it up as well.
Well, and then how long are people in the hospital for this operation?
Most people are ready to go home on the day after surgery or the second postoperative day. It's not a procedure that's associated with a lot of pain at the incision site. We generally give some local anesthetic that's long-lasting at the end of the operation, so the whole area is numb for 8 plus hours. And with Tylenol and an Advil equivalent, that's usually all that people require in order.
That's incredible.
In order to do this.
That's incredible. So that you get brain surgery and you're out maybe the next day, a day after. You take some Tylenol and that's it.
And that is it.
Excellent.
Most people take a week or two before they're back at work. Sometimes
that seems incredibly short to me too.
It's not a very invasive procedure, and it's one that's remarkably well tolerated. It's There are not that many things in healthcare that are absolutely curative. Many things are managed or medicated. This is a flat out cure, and most people never require any treatment for the condition again in their life.
That is amazing. That's amazing. Well, Dr. Martin, this has been fascinating. Thank you so much for coming on. And I know we're doing another episode with you that's going to be interesting as well. We're going to talk about that next time, but this has been a delight. And thank you very much for joining us.
Well, I think, thank you. It's been a pleasure talking to you.